This work really heals upon the fantastic mentorship of Jörg Thon, the entire RANO committee. So the RANO collaboration is a collaboration for response assessment in neuro-oncology, which aims to standardize terminology when assessing response for neuro-oncological tumors. And our working group, the RANO resect group, has a surgical focus, so we really focus on the surgical aspects of response assessment for neuro-oncological tumors. And the rationale for the current work which we are presenting here in ASCO is that terminology to describe external resection and glioblastoma really dramatically differs across the various studies which have been conducted in the last years. We know that surgical resection is a crucial part of the therapy for glioblastoma, and we know that patients in which more external resection has been achieved usually perform better compared to patients in which less extended resection has been achieved. However, there are a lot of dummy terms out there, such as gross total or subtotal resection, and it's not really clear how much of the tumor needs to be removed in order for a patient to match into one of those categories. Moreover, previous studies have usually quantified external resection based upon the relative reduction of the tumor measured in percentage. However, from an oncological standpoint, it makes more sense to really quantify the absolute residual tumor volume rather than the relative reduction of the tumor. So we previously published a classification system to denominate patients based upon the absolute residual contrast enhancing tumor volume. However, it's not really clear whether those categories we have proposed are really of prognostic value. And our current group's first aim was to prognostically validate this classification system. The second aim is to elaborate on the non-contrast enhancing tumor volume. So we know that most patients with a glioblastoma on imaging present with a contrast enhancing tumor core surrounded by a non-contrast enhancing rim. And whether additional resection above the contrast enhancing tumor borders translates into an additional survival benefit is so far unclear, but this would provide a rationale to denominate such patients into a category which one may call supramaximal resection. And it was the second goal, to elaborate on the supramaximal resection. And the final goal of our group's project is really to standardize terminology when speaking about external resection glioblastoma. For this purpose, we collected about 1,000 IDH wild-type glioblastoma patients from 7 study centers, large neuro-oncological centers, 2 in the US, 2 in Italy, and 3 in Germany, and all of them being diagnosed as glioblastoma according to the WHO 2021 classification. And the majority of those patients have been treated with radiochemotherapy according to current standard of care. And when stratifying those patients according to the previously published classification system based upon the residual contrast enhancing tumor volume, we found that this is indeed of prognostic relevance. So patients in which all or almost all of the contrast enhancing tumor has been removed experience better overall survival compared to patients in which in which just some of the contrast enhancing tumor volume has been removed, and those experience better survival compared to patients in which no tumor, so just a biopsy, has been performed. And interestingly, we then focus on the patients in which complete resection of the contrast enhancing tumor volume has been provided, and found that patients with less than 5 cubic residual non-contrast enhancing tumor volume perform better compared to patients with more non-contrast enhancing tumor volume. And interestingly, this cutoff of 5 cubic non-contrast enhancing tumor volume has previously also been described by other working groups in the last 2 years. So this really provides a rationale to denominate such patients in a category which we called supramaximal resection, and we incorporated this category into our classification system, and this final classification system we now call the RANO categories for external resection of glioblastoma. And those have been found to retain the prognostic value both on a uni and a multivariate analysis, and we therefore indeed believe that stratification, that this is a valuable stratification tool for both retrospective and prospective clinical trials. So that's really about our work.